Retina is basically a neurosensory or a neuropigmentary tissue that is present at the back of the eye, and that is responsible for relaying messages at the eyeball and then relaying these messages towards the visual cortex for the final interpretation of the images. So that is the major function of the retina that it is performing. So knowing the structure of the retina and knowing the basic anatomical structures that are involved in the making up of this tissue, that is the mainstay over here that we'll be discussing in this particular lecture, just to give you the basic concepts towards this particular neural tissue that we're talking about. So first of all, we'll be discussing the anatomical structures that are related to this retina. Just to give you an overview and the basic background towards this tissue, it's basically divided into the peripheral retina, and then we have the central retina over there. So these are the two structures, or these are the two faces. On one hand, we say there is a posterior pole of the retina, and then we have the peripheral retina that we talk about. So this is the basic anatomical configuration of this particular tissue that we're going to study right now. Just to give you the basic anatomical details that are related to this retina that we're talking about, one should know that we have this optic nerve that is adjunctioning towards this retinal tissue just at the back of this, just at the back of the eye. So this is the mainstay that you have to basically conceptualize this fact that the optic nerve is entering at the retina. When we have these structures that are quite related, or when we look at the retina on fundoscopy or retinoscopy that is performed with the help of an ophthalmoscope, we visualize this particular optic disc that you can see over here. So whenever you see this pale colored optic disc that is basically nasally located, and we have a reddish colored macula that is more temporally located in relation. When we look at these two basic structures on retinopathy, you should identify these structures that we have an optic disc that is basically nasally located, and we have a macula that is more temporally located over here. So the optic disc that we can visualize, or the optic cup that we can visualize, which is basically a physiological cup that is present on retinoscopy, that is quite physiological, and you won't consider it to be a pathology on retina. So you should have this background knowledge before you attempt to perform the ophthalmoscopy. You should have this background knowledge that we're going to look at an optic disc, and then we're going to find a macula. And then further on, you can look for any pathologies if they are present in that particular person of whom we're talking about. Then we have the fovea. So the fovea is basically located inside the macula, and it's responsible for the central vision of a person. So again, it's one of the very important structures that one should identify. Basically, the eyeball has three protective layers. We have the retina on the innermost side, then we have the choroid, and then finally on the outermost side, we have the sclera. As you can see over here, the outermost covering of the eyeball is sclera, we have the choroid, and then we have the retina to be the innermost layer. Apart from providing all of those protective functions, it also has a very important neurosensory end organ for the vision. So any damages that can occur to retina, or any congenital anomalies, that is basically the by-birth defects that can occur at the retina, are going to affect the vision of an individual. So this is the main gross anatomical structures that we're going to see when we are going to focus on the retinal structures. Then we have the ora serrata. So ora serrata is again a term in which the level of the neurosensory layer of the retina ends up over here, and that is basically termed as the ora serrata anatomically. Then we're going to focus on what are the typical, it's basically a diagrammatic review. When you're going to look at the retina, while performing the ophthalmoscopy, what are the particular structures that you're going to find. So it's just to give you a diagrammatic review regarding the retina of an individual when performed an ophthalmoscopy, or either this retina can also be visualized by using the 70D, or we can also use the 98D lenses. On the other hand, these lenses are also known as the Goldman lenses. So these are the particular lenses that are used to just visualize this retinal tissue. So just to have an overview, this is the optic disc. So this is a physiological pallor that is present at the optic disc. You're going to examine the complete normality of this optic disc. There should be a cupping phenomena seen at the optic disc, and as it is quite an avascular organ, so it looks quite pale when you just have an overview of just when you're just looking at the retina while you're performing the fundoscopy. On the other hand, we have macula, and this macula is basically, we have the most central portion, which is called as the fovea. Then we have the fovea centralis, then we have the umbo. So these are the particular terminologies that are used when we are looking at the macula, and you find any pathology that is related to this macula, may it be the drusen formation, or may it be the pallors, or it can be any papillopathies that are present over there. So that is basically, you're going to identify them and you're going to document them accordingly. If they're found in the macula, you're going to document them whether it is present in the fovea centralis or whether it is present in the umbo. That is the most central portion of the macula that we're going to talk about. The overall view, or the overall area of the retinal tissue, is almost 266 millimeters square. That is the overall area that it is covering, or that it is that is basically occupying in the eyeball. And then basically we also divide this retinal tissue into a posterior pole, and then we have the peripheral tissue. So this is basically the posterior pole. When we're visualizing it through the fundoscopy or through the ophthalmoscopic view, it's basically the fundus, or it's basically the posterior pole that we're visualizing, and we're not going to see the peripheral tissue on fundoscopy. The most important structures, that is the optic disc as well as the macula, that they're also lying at the posterior pole. So the posterior pole is the most important anatomical area that we're going to study. Also, the other most important things are the arteries and the vasculature that is present at the retina. Any abnormalities that are being detected in this vasculature, it can be the plaque reviews, it can be the cotton wool appearances, as in the diabetic retinopathies. So all of these imageries can be documented. Once you find any abnormalities that are related to the vasculature, that can be documented accordingly. Then we have a thin equatorial line on the retina that is again separating the posterior pole from the peripheral retina. So it's basically an imaginary line, and it's dividing the posterior pole from the peripheral retina. So these are the important terminologies. When we're going to describe the retina and the diseases that are related to retina, one should know how to use these terminologies and what are the particular findings when we're looking at the anatomical structures of the retina. So this is the optic disc that is more nasally located. And on the other hand, we have ora serrata, that is basically a cribriform plated tissue that is giving you an overview that the retinal tissue is ending over there. So that is basically termed as the ora serrata. And then we have the macula that is responsible for the central vision of an individual. So these are the major anatomical structures, and we're going to study the diseases that are related to these anatomical structures. This is the parafoveal region. So any region that is surrounding the fovea, that is the most central part, will be known as the parafoveal region of the macula. And the most central part is known as the foveola, or it's also known as the foveola centralis on the other terms. We have the fovea that is surrounding the foveola, or the foveola centralis. And then we have the peripheral retina over here. So we have a posterior pole, and on the other hand, we have a peripheral retina that we're going to discuss. The retinal vessels are also shown in this diagram. The veins, the arterial, all of this vasculature, and the abnormalities related to these are again very important over here. So this is the gross anatomical structure. As you can see, that was a diagrammatic review of the retina. And over here, it's the view that you're going to observe when you're going to perform the fundoscopy or when you're going to perform the ophthalmoscopy in such individuals. So this yellow spot is basically what we're going to look at. Any yellow spot, we're going to look that there is the avascular zone that is present in the macula or not. That is basically the FAZ. It's abbreviated as the foveolar avascular zone. So if it is present, it's a normal physiological finding. This is the macula, it's almost temporally located. And over here, you can see that the nasally located portion, the pallor is present over here. And we can also observe the physiological cupping phenomena, which we talked about. And that is mostly present on fundoscopy or when you perform the retinoscopy using an ophthalmoscope. Then you're going to look at the vasculature and you're going to find out any abnormalities. It can be the cattle trucking phenomena that is indicative of the atherosclerosis or any hindrance in the blood vessels or in the blood supply. And as well as you're going to look at the veins, and all of this is going to be identified over here. So these are the particular findings which we're going to find, and any pathology. This is a normal view, and if there is any pathology that is related to, or you can find any pathologies on fundoscopy or ophthalmoscopy, you should know how to document these pathologies in detail over here. Then moving on to the microscopic view of the retina. So it's basically a pigmentary epithelium that we're going to talk about. Whenever we look at the layering of the retina on the microscopic examination, there are these particular 10 layers that we're going to talk about. So this is a diagrammatic review that is briefly giving you an overview regarding the different histological layers that we're going to see or that we're going to observe in the retina. Overall, we can see that we have the pigmented epithelium, and moreover, we have the rods and the cones, we have the external limiting membranes, the outer nuclear layer, the outer plexiform layer is present over here. Then we have the inner nuclear layer almost lying over here. We have the inner plexiform layer that is lying over here. And then we have the ganglionic cell layer that is lying almost beneath. So these are the 10 layers that we usually observe. There is a mnemonic that can be used to memorize these 10 layers that is basically briefed as proling. So in proling, you can observe that P stands for the pigmented layer. Then we have the rods and the cones. And on the other hand, we have the outer layer, we have the limiting membrane, we have the inner layer, then we have a nuclear layer, and finally we have the ganglion cell layer. Just to memorize these membranes and just to keep them in mind, you can remember the word proling to just visualize these histological layers of the retina. Now they have their own functionalities. We will be detailing these functionalities, just as when you look at the pigmented epithelium, there is a Burke's membrane over here. So this membrane that it is lying on, it is known as the Burke's membrane. It is also providing the metabolic support as well as the anti-refractory layer of the retina when we're going to talk about it. Now there are some interphotoreceptor matrices that are present over here, almost over here. There are these matrices that is basically the adhesion molecules, the collagens, the CD4s, that is basically providing you the stability to the whole retinal tissue that we're talking about. So this is the functionality of the pigmented epithelial layer that we're going to talk about. And then we have the rods and the cones. So the rods and the cones have their own functionalities. When we talk about the rods, they have their particular photoreceptors that we're going to say. So even the rods and as well as the cones, they are acting as the photoreceptors. The particular pigment that is responsible for it is the rhodopsin and the scotopsin on the other hand. So these are the particular pigments that are responsible, or these are the particular cells that are responsible for the vision. Now, the functionality of the rods mainly, as you can remember, is the accommodation towards the dim light. So this is the major function of the rods, that it is performing. The low illumination and the visual acuity at the low illumination is performed by the rods. On the other hand, we have the cones. So the cones, if you differentiate or if you compare the rods from the cones, we have a lot of rods and only a small number of cones. So it's basically almost 120 million rods, and on the other hand, we have almost 6 million cones on the other hand when we are viewing this layer of retina. And the cones are responsible for the central vision on the other hand. So you have to remember their functionality. Rods are responsible for accommodation at low illumination, and the cones are responsible for the central vision and the clarity of the central vision. So this is the photoreceptor organ of the retina. When we visualize it, or when we summarize this particular structures of the retina. On the other hand, we have the external limiting membrane after this. Now, what are the particular cells? We have the horizontal cells, the bipolar cells, the amacrine cells that are present in this limiting membrane, and that is basically sequestering the formation, and they are basically making a communication between the different layers. So the limiting membrane is quite fenestrated and is allowing the communication between the different layers of the retina. Then we have the outer nuclear layer. We have the stratum opticum over there, and it's basically the collection of the axons that are present over there. We have the outer plexiform layer thereafter, and then we have the inner nuclear layer. Again, there's basically a lot of ganglionic cells that are present over there. On the other hand, we have the inner plexiform layer that is again fenestrated, and its function is again to communicate between the different layers of the retina. And finally, we have the ganglion cell layer. So it's the relaying function is basically performed by this ganglion cell layer. The messages are being relayed through this ganglion cell layer. So these are the major layerings of the retina on microscopic examination. When you perform the microscopy or histology, these will be the particular layers that are binding together, and finally they are giving the functionality towards the whole retinal tissue. So may it be the stability that they are giving, or it's the major photoreceptor organs are the rods and the cones when we talk about it. And then we have the nerve fiber layer that is basically sending back the messages towards the visual cortex, or giving out the messages towards the visual cortex for the interpretation of the images. Finally, we have the internal limiting membrane that is again performing the main function of the internal limiting membrane would be the stability that it is providing towards the retinal tissue. Then we have the fovea. So we already had a look at the macular tissue. The macula was basically responsible for the central vision, and the most central portion of the fovea centralis, or of the fovea or of the macula, was the fovea centralis. So over here, we're just giving you the gross anatomical or the microscopic view of the fovea centralis. We have the ganglion cell layer that is located over here, and then we have the internal limiting membranes that are located over here. This most central portion of the fovea centralis is basically known as the foveola when we talk about it. That is basically giving you an overview that regarding the fovea centralis, they have the blood vessels. But when you look at the foveola, it's an avascular tissue, and this zone is also known as the foveal avascular zone, abbreviated as FAZ in a lot of tissues. In a lot of individuals, there is a variation, and even this zone is being supplied by the cilioretinal artery over here. Apart from this cilioretinal artery that we're talking about, the major blood supply for this retinal structures is the central retinal artery. So in cases of this central retinal artery, whenever it is occluded or there is an incidence of the central retinal artery occlusion, which is quite a phenomena and it's quite an emergency in a lot of cases, in these individuals in which there is a bypass of the cilioretinal artery, they have a defensive mechanism, and that is basically a defensive mechanism that is provided to these individuals. When we talk about the central retinal artery, it has its four major branches. We have the superior nasal branch. On the other hand, we have the inferior nasal branch. Thirdly, we have the superior temporal branch, and finally, we have the inferior temporal branch. So these are the four major branches of the central retinal artery when we define it or when we look at it. These all branches are basically forming a vascular loop that is sometimes known as the circle of Zinn, and it's also termed as the circle of Henle in a lot of individuals. So then we have the nerve fiber layer that you can see over here. We have the inner plexiform layer that is again a fenestrated layer and making a communication between the ganglionic cell layer and the inner limiting membrane layer. Basically, we have the inner nuclear layer that is situated over here. Then we have the retinal capillaries, as you can see over here, and I've already emphasized on this fact that this foveola zone is usually avascular. Then we have the Henle's layer. Then we have the outer nuclear layer, and finally we have the choriocapillaries that is responsible or that is making out the blood circulation towards this structure of fovea centralis. Then we have the elongated cones. As you can see over here, there are these elongated cones that are present over here. You may notice this fact that this area doesn't contain any rods. So it's only the cones that it is containing, and you should focus on this fact. Then we have the pigmented epithelium. Finally, so looking at the microscopic structural review of the fovea centralis, you should get to know these structures. They are quite similar to the retinal structures or the retinal layers that we've already discussed, except for the fact that you notice that this special tissue is not having the rods. It's not responsible for the dim light illumination or the accommodation reflex. It's just the cones that are present over here. Whenever we classify the congenital disorders that are relating to the retina, we should know that it can involve the optic disc, it can involve the macula. On the other hand, it can involve the nerve fiber layer or the ganglionic cell layer. And on the other hand, we have the diseases that are particularly related to the retina proper. So these diseases that are not classified as to be relating to the optic disc or to the macula, we define them as the diseases that are particularly related to the retina proper over here. The anomalies of the optic disc would be, on one hand, we have the colobomas. So just to give you an overview, what is a coloboma? It's basically a ring defect that is produced congenitally or by birth. It's basically a developmental disorder that is due to the mutations at the genetic level. So these ring disorders can be involving the iris, it can be involving the lids, and even it can be involving the retinal structures, it can involve the lens, the maculas. So all of these structures can be involved when we are looking at the colobomas or when we are defining the colobomas at this level. Particularly when we say that a coloboma can also occur at the optic disc, or this ring defect can occur at the optic disc. The gene that is particularly involved in the coloboma formation is the PAX6. It's basically PAX6. This is the PAX6 genes that are responsible and that are mutated at the genetic level and that are responsible for these ring defects to occur. The DNA is not prescribed normally in a mutated tissue, and a mutated PAX6 results in a lack of a transcription factor at this level. So this is the whole pathology that is basically lying behind this congenital defect or this congenital ring defect that we usually encounter. It can result in the minor defects, and on the other hand, we have the ring-like major defects that can be observed on retinoscopy. So it can involve the optic disc, the clinical features or the clinical manifestations of this particular coloboma, which is occurring at the optic disc. It is going to severely interfere the vision in these individuals as well. This is basically a diagram that is briefing or giving you a review regarding the mutated eye cells that we talked about and that are going to result in a coloboma defect in the newborns. As I've already mentioned, this coloboma can occur in the iris. As you can see over here, it's a ring defect in the iris in this individual. It can be the lens that is affected in a lot of cases. It can be the retina in a lot of cases, and particularly it can be the optic disc in a lot of cases. On retinoscopy or on ophthalmoscopy, you will see this yellowish discoloration or this palish view that is far more than a normal optic disc. So it's quite larger or it's quite elongated, and that is going to be observed when you're going to perform the fundoscopy or ophthalmoscopy in these individuals. This is going to be a more magnified view of this ring defect in the optic disc. So this is going to be a general view. The clinical manifestations or the clinical presentations regarding this coloboma would be a decreased visual acuity in these individuals. At the retinal level or at the optic disc level, the surgical management is not possible. But if it is occurring at the level of the iris or if it is involving any other superficial structures that can be treated, we can perform, for example, if it is occurring at the eyelids, we can perform the surgical procedures to cover up this defect and to avoid the complications that are related to this coloboma. So at the optic disc, we have the other anomalies, for example, the drusen formation. So what does a drusen look like? If we look at the optic disc, you are going to find out these intrapapillary bodies or the diffractile bodies at the optic disc that can be observed at the physiological cupping phenomena. It can be a complete ring defect that is seen in these individuals, as you can see over here. And this is basically foremostly, it's just appearing as a papilledema, that is just a swelling of the optic disc. But finally, it will be observed that these are the intrapapillary structures, that there are some drusen formations that are occurring at the optic disc. As you can see, even in this, these angiographies that are performed for the retina, that will give you a radiographic view of these particular drusen formations at the optic disc level. So even a lot of radio imaging are performed in these kind of drusen formations. As you can see over here, these are the particular structures that are found on the radiographic imaging, and that is sometimes quite useful in a lot of cases, in the diagnosis of a lot of cases. So again, the clinical manifestations even in such cases would be a decreased visual acuity, and even it can cause complete blindness in a lot of individuals. There are a lot of medical managements that are available for these congenital anomalies at the optic disc, specifically the drusen formation. Then we have the hypoplasias. The types of the hypoplasias usually occur bilaterally in almost 60% of the cases. The causative factors for the development of the hypoplasias are usually the use of alcohol. Maternal alcohol use is one of the major causes for this hypoplasia at the level of the optic disc. Then we have diabetes, and then a lot of the maternal drugs also appear to be a cause of the development of the hypoplasia at the optic disc. We have a type 1 variety that is basically the optic nerve hypoplasia simplex. Then we have the type 2 variety known as the septo-optic dysplasias, and then we have the type 3 variety that is basically the septo-optic pituitary dysplasias in a lot of individuals. So we have the normal, and on the other hand, we have the ONH, that is the optic nerve hypoplasias, that is noted down in a lot of individuals. So we have the optic nerve head, as you can see over here, and this is basically the review. As you can see over here, the optic nerve head is quite smaller in size. That is the main clinical feature or the clinical presentation that will give you, and that is quite helpful in the diagnosis of the optic nerve hypoplasias in these individuals. The macula, as you can observe over here, it's quite shortened, or it's quite smaller in size as compared to over here. So the comparative studies are sometimes quite important. If it is not a bilateral case, you can perform the comparative studies in the same individual. And on the other hand, if it is a case which is 60% of the cases, it's a bilateral phenomena that is seen in the children. Then we have the anomalies of the nerve fibers. We have the medillated nerve fibers, we have the enlarged nerve fibers, and due to the lamina cribrosa, they are found to be medillated. The presentation would be somewhat like this. The pallor that is present over here, that would be the main diagnostic factor when we have these medillated nerve fibers, and we are being suspicious. We perform the fundoscopy or ophthalmoscopy in these individuals, and we find these pale sites that are surrounding the optic disc. That is basically indicative of the fact that the nerve fibers are myelinated beyond the level of normality. So this is basically the clinical presentation or the findings that you're going to observe when you perform the fundoscopy in these individuals. The hyaloid artery is the usual presentation of the hyaloid artery as you look at the normal individuals. It's basically a remnant structure. In the adult life, it is not present. So it is diminished, and that is the normal case. Now, there are three varieties if there is a persistent hyaloid artery in the individuals. On one hand, we have the Bregmaster's papilla, then we have the Mittendorf's dot, and then we have the vascular loops that are sometimes found over there. So when we look at the Mittendorf's dot, it's basically the attachment of the hyaloid artery towards the posterior pole of the lens, and sometimes it presents as the posterior polar cataract. So majorly or highly, you can just observe this fact that the persistence of the hyaloid artery in the adult life, or when the baby is born, even after that, if the hyaloid artery is persisting, that is an abnormal tissue that is present over there, and is going to manifest as a cataract, or even the Bregmaster's view, or even it can be a loop that is not attached to the lens, but it's still present when you perform the fundoscopy. You see that vascular loop that is present in the vitreous, or that is present in the posterior chamber of the eye. So this is the phenomena of the hyaloid artery or the persistent hyaloid artery that can be present. And these vascular elements, when we perform the fundoscopy or ophthalmoscopy, we can visualize these persistent hyaloid arteries. As you can see over here, it's quite visible that an artery is present over there. It's persistent hyaloid artery, this palish or whitish shadow that can be seen when you perform the ophthalmoscopy. That is the evidence that there is the persistence of the hyaloid artery over there. Then we have the congenital tortuosity of the vessels. The vessels are sometimes accentuated, they are sometimes quite tortuous, so you should know how to distinguish the normal vasculature of the retina from any abnormal vasculature in the retina. As you can see over here, it's not a normal vasculature. There is a lot of tortuosity that is seen in these vessels, which is not quite normal. But you should keep in mind the normal view of the retina that you've already observed previously. Then only you can compare, and then only you can diagnose that this person has the accentuated vessels, or these vessels have some atherosclerotic changes in them. So that is going to be just diagnosed when you can have that comparison in your mind for the normal vasculature of the retina. So it's one of the anomalies of the vascular elements that can be present congenitally in an individual, and then you're going to observe if there are any atherosclerotic changes, if there are any cotton wool appearances in these phenomena, or if there is any cattle trucking phenomena that is seen in the retinal vessels in a lot of cases, and that is again indicative of the atherosclerotic plaques in these individuals. So knowing the normal vasculature and then their comparison is the mainstay when you are observing the retina of the individual. Albinism is another congenital disorder. On a whole, it's affecting the whole individual on a broader view, but it's also affecting the visual acuity of the child. The range of the visual acuity is reduced in these individuals who have albinism, and there is an underdevelopment of fovea that is observed in these individuals. And then we have the ganglionic cell layer. The ganglionic relay is also affected in these individuals, in these albinistic babies who are basically lacking the pigment in them. Now, this is a normal eye, and when we compare this relay mechanism in which the messages are sent from the relay area to the visual cortex, you can observe that the optic nerve is basically sending messages from the retina towards the visual area. And on the other hand, we can observe that there is an albinistic view where the overlay of the tissues at the optic chiasma is quite overviewed, and the ganglionic cell layer over here is quite disturbed. The images are not going to be quite fast. Over here, the central vision is going to be affected in these individuals, and there are multiple reasons for the development of the reduced visual acuity in these individuals. The relay area is basically the same, it has no abnormality, but still there is an overlapping of the optic nerves that is seen in these individuals. So over here, you can see that there is a lot of pathology that is seen in these albinistic individuals. When we see at the retina of these albinistic individuals, the pigmentary layer on a whole is disturbed, the vasculature is disturbed, and the optic disc, even the macula, all of these structures are quite not in a normal view when we look at the vasculature or when we look at the other gross anatomical structures that are important for the normal functionality of the retinal structures. Then moving on to the congenital night blindness. So what is the pathophysiology between the congenital night blindness in these individuals? There are the rod cells, which are activating the bipolar cells and the visual signals, and the other retinal cells are then activated and they are sending messages. Basically, what is happening over here is the rhodopsin is activating the PDE cycle, that is the phosphodiesterase cycle, and that is basically closing the calcium channels. When there is a lack of the cellular calcium levels, that is basically responsible for the dim light that is perceived by the brain. Now, whenever there is a photoreceptor, a genetic mutation, the rod cells or at the level of the bipolar cells or at the level of the retinal cells, the visual signals would not be sent for the basically for perception of the dim light. So that is the main pathogenesis behind the congenital night blindness of the individuals. That can be one of the congenital pathologies that the individual can encounter. As you can see over here, the photoreceptor rhodopsin is mutated, or the gene for the rhodopsin is mutated in these individuals who are suffering from the congenital night blindness. Then we have the Augusti's disease. The Augusti's disease is, again, we can just have a look. Again, these individuals are suffering from the light blindness, the rhodopsin or the photoreceptor rhodopsin. There are the mutated SAG. It basically prevents the receptor inactivation. The dark adaptation is delayed in these individuals, and the dim light is not perceived quite accurately. There are the activated receptors, and then we have the transducin that is activated. And finally, there are the multiple steps that are responsible for the perception of the dim light. In Augusti's disease, we have the mutated SAG that is preventing the inactivation of the perception of the dim light, and we have the mutated photoreceptor visual cycle in these individuals. Again, you will be able to see the Augusti's disease. You have this photoreceptor rhodopsin. The genetic mutation for this is seen in these individuals. We have the congenital retinal cysts that can be seen at the level of the lamina cribrosa. We have the retinal pearls. They are of different sizes, and they're usually filled up with the proteoglycan material. So they can be sometimes visualized as the intrapupillary structures in the retina. As you can see, there are the retinal pearls. They are of very small size, and then you have the bigger cyst, that is the cyst of the pars plana. So these different retinal cysts are sometimes observed, and they can sometimes cause the visual problems as well. The congenital retinal detachments can be rheumatogenic, as it can be due to the coloboma defects in the retina that causes the retinal detachment, or either it can be the trauma that is leading towards this retinal detachment. It can be a lot of infections even that can be related to this congenital retinal detachment in these individuals. This is the fundoscopic view of the retinal detachment that is diagnosed in these individuals. The coloboma of the fundus is one of the major causes for the development of the retinal detachment after that. And then we have the aplasias. So aplasias, hypoplasias, colobomas, these are the main maculopathies that are observed congenitally in the individuals. Aplasias can be detected on fundoscopy, and they are particularly responsible for a visual field defect that is most central in its occurrence. Then you can also observe hyperplasia at the macular level. These are again going to manifest, and they're again going to manifest as the visual field defects that are affecting the central vision in these individuals. The coloboma defects or the detachment defects, the ring defects, they can also be observed at the macular level. We've already studied them at the other levels. The optic disc or the optic nerve, the eyelids, the iris, and after that the macula can also be affected by these ring defects. The mechanism is same of the PAX6 genes and the mutations at this level. So that is basically, we discussed the basic major anatomical structures of the retina and what are these anatomical structures functioning through and helping out the retina to perform the basic function of relaying messages towards the visual cortex. And then after that, we discussed the congenital disorders that are related to this retina and the retina proper and optic nerve and the macula, and how they are going to affect the vision in these individuals. So that is the end of this lecture. Thank you for watching sqadia.com.